That's not have time for questions. So
Make no shot.
After the session,
Gambling time.
So thank you very much for the next one. So the next speaker is Marie-Anne Engh from the Semmelweis University, and she works as a systemic review and meta-analysis of gastrointestinal bleeding.
All right, hi. So for those of you who don't know me, which is most of you probably, my name is Marie Engh. I'm a first-year PhD student working with Peter Henke here in Budapest. And I'm not quite sure why I'm in the chronic pancreatitis session, because I would actually like to present my meta-analysis about the proportion of acute pancreatitis patients affected by gastrointestinal bleeding. Gastrointestinal bleeding was one of the organ failures that was used to classify severe acute pancreatitis in the original Atlanta classification. This was later removed because the impact on mortality was not big enough compared to the other organ failures. Severe bleeding following acute pancreatitis may carry a high mortality rate of 34%. And a large population-based study found that this is the case even when corrected for the presence of other kinds of organ failure. There is no clear data in the literature on how many patients this actually affects. So our clinical question was to examine the condition of gastrointestinal bleeding in a context of acute pancreatitis in a population of adult patients. And by this, we would like to know what clinicians may expect and how many patients might this happen. We performed a systematic search for concepts of pancreatitis and gastrointestinal bleeding in 3 databases and found 11,400 records, which were screened in duplicates with disagreements resolved by a third reviewer to give us 20 records in the end, covering 120,000 patients. We then extracted the data, did a risk of bias assessment, which found that most studies had a low to moderate risk of bias. And without further ado, these are our results. We found that 4% of patients suffered gastrointestinal bleeding, albeit with a high heterogeneity of 86%. So the results are not that solid. We decided to compare the studies which included patients before the Atlanta classification to those which included them after the Atlanta classification to see if this somehow affected results. It did not. We also investigated the rate of gastrointestinal bleeding in severe acute pancreatitis patients, which was of course much higher at 16%. In this case, the heterogeneity was lower, so we also have a prediction interval of 13 to 20%, meaning that further studies will likely find the same numbers. We wanted to investigate the different causes of gastrointestinal bleeding, so we also looked at gastrointestinal bleeding caused by sinistral portal hypertension, which is exceedingly rare at 0.2%, and the gastrointestinal bleeding from pseudoaneurysms, which are also exceedingly rare at 0.4%. In conclusion, our main finding is that bleeding occurs in about 4% of acute pancreatitis patients and in 16% of severe acute pancreatitis patients. Based on this, we think that risk of bleeding should be a factor when considering prophylactic anticoagulation in these patients. We also think that clinicians should be on the lookout for bleeding, particularly in severe acute pancreatitis. And we would like to further investigate the impact of gastrointestinal bleeding, as well as the impact of bleeding prophylaxis on outcomes in severe acute pancreatitis. Thank you for your attention, and I welcome questions and comments.
Professor Wittkamp, question.
Yeah, so I have several questions for you. First of all, how did they define gastrointestinal bleeding?
The definition was not always the same, but in most studies after the Atlanta classification, they used 500 milliliters per 24 hours. So the one that is actually defined in the Atlanta classification.
So is it a drop in the hemoglobin or is it actual bleeding?
It is actual bleeding.
Okay.
But I remember from your presentation that the hemoglobin drop might also signify the severity or signal that this will be a severe case. In this case, it was actually bleeding. So, you know, there might be some overlap between why the severity is.
So two other observations that are interesting. First of all, is that in patients that are transferred into us, those who have not gotten adequate fluid resuscitation may have intestinal ischemia and have bleeding from that, which we have seen several times. The other thing is there was, I believe, a report suggesting that people that got acid suppression were at higher risk of bleeding, which is counterintuitive. I was wondering if you saw any of that type of effect.
This was not included in our study. However, there were two studies which we found which were looking at the impact of acid suppression on fecal occult blood tests. And those actually did find that the rate of positive fecal occult blood tests was higher when given proton pump inhibitors. So it doesn't necessarily mean it's bleeding because it's not a very good definition of bleeding, but it did find that the rate of fecal occult blood tests.
Which seems counterintuitive. So
it really does. I don't know why that would happen, but I found the same. Yeah.
Did you see in those papers the number of bleeding due to ERCP and biliary acute pancreatitis, for example?
We actually excluded studies that were only on the iatrogenic causes of bleeding. So in cases where it was a population that had received ERCP or it was post-ERCP pancreatitis.
So you didn't consider that?
No.
Okay.
Yeah.
So I mean, your rate of pseudoaneurysm was low, though only recently I heard a talk where they reported the rate of pseudoaneurysm in severe acute pancreatitis being 4%. So I was wondering whether by the definition you used to actually search for your publication, you would pick up the cases with pseudoaneurysms, because I would not necessarily associate them with GI bleeding.
Right, so this is not the rate of pseudoaneurysm overall, this is the rate of gastrointestinal bleeding caused by pseudoaneurysm. There were several cases where patients had pseudoaneurysms or pseudoaneurysms bleeding into the peritoneal cavity. We didn't include these because we were actually looking at the clinical manifestation.
Then it's not pseudoaneurysm, but then it's a hemophagus pancreaticus, or?
Right, so I mean, it's gastrointestinal bleeding caused by a bleeding pseudoaneurysm. So we only considered those where it actually was an intraluminal bleed. And we actively excluded the cases that were not intraluminal.
Thank you.